I work for HIMSS North America, so we are, HIMSS is based in Chicago. I work out of our Washington, D.C. office, and so I'm going to try to help understand what's happening in Washington, D.C. right now. When I kind of thought about my presentation, I tried to divide it up into two separate sections. One is what we know, and I think we have some clear signals on a couple things thus far, but I think the longer part of my presentation is really on what we think we know at this point. So, and then I also want to talk a little bit about how to get involved and leverage HIMSS and take advantage of the great infrastructure that you all have here in Southern California from the HIMSS Southern California chapter. And then definitely have time for question and answer. And I would say too that if folks have questions or comments during my presentation, please just raise your hand and we can try to address them there. I will try to simplify things as much as possible, but as you know, a lot of these policies and regulations and so on that we talk about are not easy to understand. So I totally get it, but so please don't hesitate to just stop me. So I think it's important to mention where we're at. So HIMSS is a cause-based organization. What we really focus on is health IT enabling healthcare transformation. So, our real charge is about advancing the value of health IT to support healthcare transformation. And luckily, I think that health IT is a bipartisan issue in terms of Republicans, Democrats, folks are definitely supportive of health IT. The devil is obviously in the details for a lot of that, but in broad strokes, health IT is a bipartisan issue. And right now, I think we're at an interesting point in terms of advocacy, in that we are moving from the widespread implementation of health IT. And that was as a result of the EHR incentive program and a couple other policy levers. And now we're moving to trying to drive improvements using IT for care delivery and access to care, health outcomes, and costs. So I think that by and large, federal and state policymakers realize the promise of health IT. There is somewhat of a catch-22 between the speed of innovation of the marketplace and the pace of government regulation. So that's something that we try to address through some of our policies, and I know a lot of folks within the government are thinking about that as well. So that complicates things a little bit and adds to the complexity, but I think our trajectory is definitely in the positive direction. So what we know. President Trump has key health policy leaders in place. Representative Dr. Tom Price is a former member of the House of Representatives. He was confirmed as the HHS Secretary on February 10th. He was a House member for 6 terms from Georgia, right outside of Atlanta. And he also is an orthopedic surgeon by training. So I think he understands how healthcare is delivered. And then I would also say that in his role in the House of Representatives, he was also the chair of the House Budget Committee, which is in charge of setting kind of the broad policy, fiscal policy direction for the entire federal government. And so I think he understands from the delivery side, but he also understands a lot of the fiscal concerns, Medicare, Medicaid, other outside of healthcare, other programs. He also has a lengthy record on health reform issues. He worked back in 2009, 2010 in proposing some alternatives to the Affordable Care Act. So he, I think, has been a key player as the American Health Care Act and health reform efforts have moved forward in the Trump administration. So we also have Seema Verna, who is the CMS administrator. She was confirmed in the middle of March. She has extensive experience in Medicare and Medicaid. On the Medicaid side, she was the architect of the Healthy Indiana Plan, which was Indiana's version of Medicaid expansion under the Affordable Care Act. That was really one of the big issues where she spent a lot of her time. And I'll talk a little bit in a few moments about how that has kind of manifested itself in the new CMS in her new CMS role. So she also worked on more general health reform efforts under the Affordable Care Act in Indiana. So at the HHS level and the CMS level, we have the two key leaders in place. I would also say that we have a new national coordinator that was named about a month ago. So this is the National Coordinator for Health IT within the Department of Health and Human Services, reports directly to the Secretary of Health and Human Services. So Don Rucker is the new national coordinator. So his background is as a bioinformatics and emergency medicine professor at Ohio State. So he has that experience of healthcare delivery, understanding the informatics side, which I think is important. And then also, he has the vendor perspective, because he did spend 13 years as the Siemens Healthcare Chief Medical Officer. So delivery plus vendor side makes him kind of having the ideal background for doing the job as national coordinator. John Fleming is a former member of the House of Representatives, and he is in a new position within HHS, within the Office of the National Coordinator, that reports to Dr. that reports to Dr. Rucker. So Dr. Fleming is the Deputy Assistant Secretary for Health Technology Reform. He was a representative from Louisiana for 4 terms. And he's an MD by training. He was an early adopter of health IT, installing his EHR back in 1997 for his medical practice. So, and he also spent some time in the U.S. Navy Medical Service. So, one point that I will mention is that the idea of value-based care is a bipartisan issue, and something that Republicans and Democrats both are supportive of. There is the economic argument about value-based care supporting and helping to extend the sustainability of the Medicare Trust Fund. Depending on who you ask, the Medicare Trust Fund has anywhere from 10 to 20 years left before, and that's with no policy changes, has 10 to 20 years before it faces bankruptcy. So the idea of an economic argument and a value-based care helping to lower cost, improve outcomes, which eventually, again, compound the lowering of the cost, is something that's important. And also, when we talk about President Trump's economic agenda, the idea of lower healthcare costs is something that should figure prominently in that. And then I also think you have the quality argument in terms of higher quality care, delivering better outcomes, providing more value, which obviously is a part of the entire economic argument. But this idea, I think, is fundamental to a lot of the things that we're talking about, and I think it has support from both Republicans and Democrats. So what Secretary Price has spent a long time, long time in terms of the couple months that he has been in his position, is making sure that the physician burden is reduced. I think that that's going to be a real focus going forward. That's the regulatory burden, that's the reporting burden, making sure that that is reduced on physicians. He wants to create a system that practitioners have more time to spend with patients, that physicians are that are patient-facing and not computer-facing when they're interacting with patients. He also has talked about aligning reporting across multiple programs. There are several programs between Medicare and Medicaid and subsets of those programs where physicians and clinicians in general are required to report the same thing to multiple CMS portals and so on. So trying to figure out how to align all those programs so a doc in private practice can just report one thing, and that would cover multiple programs. So they're trying to make strides in that area. I think one of the other areas has to do with mandatory requirements for participating in some of the new payment and care delivery models. That's something that he has spoken out loud and clear about. Hopefully most folks are familiar with the Center for Medicare and Medicaid Innovation. They created a lot of the accountable care organization programs that CMS is running. There are some bundled payment programs that are part of that are that were mandatory and were intended to be mandatory going forward that Secretary Price's and the rest of the HHS administration has decided to not make mandatory anymore. So, so there are different, definitely different pieces to all this. You know, hopefully folks can recognize some of the acronyms that I have here in terms of the regulatory vehicles. The IPPS is the Inpatient Prospective Payment System. QPP is the Quality Payment Program. Meaningful Use is MU, and then the Physician Fee Schedule is for those physicians who are not part of the Quality Payment Program. So those different programs all have the opportunity to enact some of these policies that the Secretary Price has really talked about in terms of reducing the physician burden, reducing the reporting burden. The IPPS rule is the first rule that has been issued, the first really major healthcare related rule that was issued under the Trump administration. And that had several instances where they did lower the requirements around physician and hospital reporting. Meaningful use in 2018, not to get too much into the weeds, but meaningful use in 2018 is proposed now to be a 90-day reporting period versus a full year reporting period. And again, this would just be for hospitals, most likely because most clinicians are going to be participating in the Quality Payment Program. But I can go into a little more depth about that down the road. And then also it reduces some of the electronic clinical quality measure reporting that's in place for 2017 and also for 2018. So I would say that the Quality Payment Program, and this is MACRA, some folks still call it MACRA, but the Quality Payment Program, hopefully most folks know what that acronym is, the QPP. This is in place right now. I'll talk a little bit more about some of the details about 2017 reporting in a moment. But it's important to know that clinicians in private practice should have received a letter from CMS in the past couple weeks saying whether they are most likely in the program or out of the program, depending on where they fall. And the two thresholds that they had to meet, if they do meet these thresholds, they have to participate in the program in 2017. So if they bill Medicare Part B more than $30,000 a year and see more than 100 Medicare patients, they have to participate in the Quality Payment Program. So there are a few caveats. So if they are in an advanced APM, that's an advanced alternative payment model, that could be one of the risk-bearing ACOs or some of the other programs that I alluded to from the Center for Medicare and Medicaid Innovation. If they aren't in an advanced APM, they do not have to participate in the MIPS program and report through the MIPS program for 2017. Right now, the current estimates are that about 70,000 to 120,000 clinicians are in the advanced APM track. But what CMS is forecasting is that about a little over 418,000 physicians would report through the MIPS program in 2017, and about 806,000 would not meet these thresholds and not have to report for 2017. And I would say that there's a very handy lookup for physicians. If you just type in your NPI number, if you go to qpp.cms.gov, you can type in your NPI number and see whether you meet these thresholds according to the CMS data and have to report through MIPS and so on. So I would emphasize too that there are technical assistance grants that are out there. 11 regional organizations have been funded by CMS to try to reach out to the rural, to the clinicians that are practicing in underserved areas that may not have the kind of technical assistance and the education to participate in the MIPS program. So these grants are really have been made to try to reach out to those physicians that are practicing in the underserved areas, maybe overburdened, and need that extra information from CMS in order to participate in the program. So another thing that I'll mention is that one policy that the Trump administration and CMS has been pursuing is granting states more flexibility around Medicaid especially. So CMS has sent out a letter, state Medicaid directors, that give more freedom to design programs to meet the diverse needs of their Medicaid population. Health IT is going to be a big part of that. In terms of system redesigns at the state level. So the idea behind the push from CMS's side is improve the economic standing and help folks rise out of poverty and use the Medicaid program as a vehicle to do that. So that is something that I think we'll get more information about from the Trump administration in the near future. So another thing that I'll mention that we definitely know at this point is the 21st Century Cures Act was enacted in December of 2016. So this was a law that really focused on biomedical research. There was definitely a lot of provisions that supported the NIH, what the National Institutes of Health and the Food and Drug Administration do in terms of expediting discovery and delivery and development of new cures. But there was also a health IT component to this. Health IT was woven throughout the law in terms of harmonization and reducing of some regulatory burdens. There was a GAO study that was included in there, and the GAO is the Government Accountability Office, which often works for Congress in terms of providing expert advice. So they're working on a study about patient matching initiatives. In terms of 21st century cures, health IT was woven throughout the law, is I think the important takeaway here. Several things specifically related to health IT is that interoperability was defined in the law. So now we have a federal definition of what interoperability and health information exchange is that's in statute. So some of the capabilities that they included in this definition is about enabling the secure exchange of health information with and use of electronic health information from other health IT without special effort on the part of the user. So I think the key part here is without special effort on the part of the user. It also really focused on allowing complete access and exchange and use of all electronically accessible health information. And it does not constitute information blocking, which I'll talk about in just a second. So I think it's really important to emphasize this is what was in statute. This is going to be subject to rulemaking. So there'll be a proposed rule, most likely, coming out from the Office of the National Coordinator in the next several weeks or months that'll kind of dive into this and provide a little more specifics and talk about what special effort on the part of the user really means. But I think it is definitely a positive sign that we have a federal definition now about interoperability. So information blocking, in terms of the definition around there. There really are two tests that are a part of this. From the health IT developer exchange or network side, if the test is whether that entity knows or should know that such a practice that they're engaging in is interfering with, discouraging access, exchange, and use of health information. I think the other test is for kind of the provider side, and the provider knows that such a practice is unreasonable and interfering with that. So on the developer exchange network side, it knows or should know that some of the practices that they're implementing are interfering. On the provider side, it's whether the provider knows, whether there's not that should knows caveat in there. So again, this is going to be subject to upcoming regulations. More specifics are needed, I think, for all the folks in this room and across the country to try to implement something like this and make sure that they're abiding by the letter of the law. So I would say that technically, the information blocking provisions, enforcement of that began on January 13th, 30 days after the law was passed. So the idea is that right now, under current rules, based on the legislation, and I should say the law now, is that the HHS IG determines that information blocking has happened. That entity is actually subject to a civil monetary penalty that is up to $1 million per violation. So I just wanted to kind of keep that in mind. As we get more details, HIMSS National will definitely keep you in the loop about about this as this evolves, but this is in statute now about a $1 million fine, civil monetary penalty for folks that are not abiding by these information blocking provisions. Precision medicine is another issue that I just wanted to raise real quick. There's a lot of health IT that's a part of the precision medicine initiative, moving patient information or allowing patients to move their information from an EHR to a research database, so that research can be performed and so on, is something that ultimately the Department of Health and Human Services is trying to get to a point. The idea is that eventually we're going to be at a spot where medical treatment can be tailored to each patient. Delivering the right care to the right patient at the right time in the right setting based on their history, genes, environment, and lifestyle. I think it's important to emphasize that this is coming all across the entire federal government. The National Institutes of Health is on the front lines of this, of implementing this program. They're in the process of creating a 1 million person research cohort. The Department of Veterans Affairs is also embarking on their own effort in this way in terms of creating the Million Veteran Program, and FDA also has a piece of this. So hopefully this is something that, that you all will be hearing more about in the future. And again, when we talk about the future of the application of health IT, I think precision medicine definitely embodies that. So what we think we know. Health reform, the American Health Care Act is pushing forward. As most folks know, the bill, a largely Republican-driven bill, passed the House of Representatives and now is in the Senate. All indications are that the Senate is working on its own version of a health reform effort, using the bill that passed the House as a baseline, but not using that bill specifically. I think it's probably going to be several weeks to months until we see something from the Senate in terms of a health reform effort. The Republican plan in general terms is that budget reconciliation, and I don't want to get too much into the weeds here, but right now we're in the stage of budget reconciliation. And I think eventually we'll be moving to the stage, if the House and Senate both can pass something, and that moves to President Trump to be signed into law, then we work on administrative actions and rules, regulations from the Department of Health and Human Services. The second piece is where really HIMSS is focused on, and that's the bipartisan legislation part of it. We do not really work too much on the insurance provisions of a health reform effort. We're more focused on the third piece that's identified here, that touches on where the Center for Medicare and Medicaid Innovation and some of the other issues that really help enable the push to value-based care are included as part of the health reform effort. So it's something we're following very closely as things proceed. The idea of MIPS in 2017, how many folks are familiar with the pick your pace paradigm for 2017 for MIPS? Anyone? All right. Couple hands. Pick your pace is really 3 different options to participate and also the option to not participate. Right now we're in the process of waiting for a proposed rule for the 2018 iteration of the quality payment program. The question, one of the real policy questions out there is about whether this kind of paradigm is going to continue for 2018. I can see that that Secretary Price, in his drive to kind of reduce physician burden and provide a little more flexibility, could adopt something like this for 2018 as well as for 2017. So we'll see a proposed rule probably in the next couple weeks. Please turn to HIMSS for kind of analysis and more information about that. But this is just something that we'll definitely see in the near future, and we'll answer a lot of our questions whether this sort of pick your pace is going to persist into 2018. So it's hard, especially this week, to not mention cybersecurity. HHS is in the process of trying to figure out how they want to address cybersecurity. There are several initiatives underway at HHS to kind of increase information sharing, increase the analysis of threat information for providers, and make it actionable on behalf of the providers. What HIMSS has really pushed for is a 3-part plan. We call it our cybersecurity call to action. The 3 ideas, very briefly, are adopting a universal information privacy and security framework for the health sector. That's health sector specific. We have asked for this, kind of pointed folks towards the NIST cybersecurity framework. That's the National Institutes of Standards and Technology. There's a federal agency that came up with its own cybersecurity framework, not healthcare specific, but kind of gets us a lot of the way there. So that's something that we are trying to advocate for before HHS. We also asked for the creation of an HHS cyber lead, someone who can be the point person at HHS when something like this past week just happened in terms of the WannaCry ransomware virus, someone who's the spokesperson, the public-facing leader at HHS that can talk about what providers need to do, what the market, what the community needs to do in terms of addressing the crisis and mitigating any sort of issues. And one other thing that we really are pushing for is trying to get HHS to address the shortage of cybersecurity professionals. I don't know if folks in this room face these issues here in California, but across the country, what we heard from from providers and members is that they have a real shortage of experienced cybersecurity professionals that are out there. 59% of our respondents for our 2016 survey really identified the lack of appropriately trained cybersecurity professionals as the #1 barrier in kind of addressing cybersecurity concerns. So. One of the other issues that I want to mention is that also beginning on January 1st, 2018 is the idea of the start date of the 2015 edition Help IT criteria. What HIMSS has asked HHS to do is move the start date of the requirement around that from January 1st, 2018 to July 1st, 2018 to provide a little more time for folks to implement something. There have been some issues in terms of vendors actually getting their products certified to the 2015 edition and making that available to their customers. There are, as of just a little over a month ago, very few products were certified to the revised 2015 certification criteria. That sort of jeopardizes any sort of larger effort of implementing the quality payment program for 2018, implementing meaningful use. Those are both part of and require, as of right now, require the use of the 2015 edition. So what we've asked for is a little more time to implement something, to implement the 2015 edition. We still are definitely in favor of the 2015 edition certification criteria. It has a lot of great provisions in it and all that help support interoperability, help support the move to APIs, and so on, but a little more time would probably be something that would be valuable for the entire community. So I also want to just talk a little bit about the future of meaningful use. For those folks that work in hospitals, I hope you have heard from your different organizations as hospitals have continued to, and hospital organizations have continued to campaign for a delay in the start date for the meaningful use program. People different groups are asking for different things. Some groups are asking for a delay for the start date for stage 3, that January 1st, 2018 start date. Others have asked for modifications to provide the same level of flexibility for eligible hospitals in meaningful use as clinicians get in the MIPS program that is part of the quality payment program. So right now on the books is all providers are required to start to participate in stage 3 regardless of their prior participation beginning in 2018. The rule that is proposed is that, as I mentioned before, is that there would be just a 90-day reporting period required for meaningful use in 2018. So, but again, also this hanging over this entire effort is this idea about using the 2015 edition certification criteria. So that is an issue that's evolving that we're following closely.
Who is funding the meaningful use program now that there's MIPS?
Meaningful use is still around. CMS is funding the program. Meaningful use really is only applicable to hospitals. Well, there's the Medicare meaningful use requirements are really for eligible hospitals. There's also the Medicaid meaningful use program that is for all providers. So I can talk to you more about more specifics. It gets a little bit into the weeds, but in very general terms, most clinicians, and that's physicians and nurse practitioners and other providers in private practice, are going to report through the MIPS program, through the quality payment program, versus the meaningful use program from here on out. The other things that I'll just talk about relate to the dynamics of the Trump administration. Regulatory reform efforts are underway. The president has really talked about eliminating regulation and trying to reduce the burden of regulation. He has issued an executive order that talks about eliminating 2 regulations for every new one that's issued. Other things that he has talked about is reducing the federal civilian workforce. Just today I saw a report that the Centers for Disease Control and Prevention has 700 positions that are unfilled, that are currently not going to be filled because there's a federal hiring freeze in place. So that's the kind of thing that we could see a reduction in the federal workforce through attrition going forward under the Trump administration. The other thing that I'll point out is about the federal budget blueprint. So what happens in the federal budget process, very, very briefly, is that the president makes a proposal to Congress about broad parameters for the budget. Congress takes that and works on the specifics for each department and so on. So what President Trump, in the broadest terms possible, proposed was a $54 billion increase in defense spending for FY 2018. So that begins this October 1st, 2017 through September 30th, 2018. And what that would be is offset by targeted reductions elsewhere throughout the federal budget. So right now, HHS, under the Trump plan, and I would say that it's just the broad auspices of a plan at this point, but HHS is looking at almost an 18% decrease in funding for 2018 under the president's blueprint plan. We're going to get more specifics over the next several weeks and months, but it's definitely an issue to continue to watch. So here's my plug for just getting involved with the chapter and getting involved in general with HIMSS advocacy activities. We need to hear the voice of folks that are the boots on the ground perspective from you all that are actually out there using health IT, implementing health IT. Folks in Washington are always asking us for, what are you hearing from your members? What are your members talking about policy A versus policy B and so on? So we at HIMSS National, and I think that the folks in your chapter leadership want to hear from you about the problems that you're facing, the challenges that you're facing, the issues that you're having, things that could be better. We have a lot of opportunities to address those things, whether it's through legislation or through changes in regulation. So there are just a lot of opportunities. So I'm happy to talk to folks after this presentation. I know I'm running short on time, but about things that we can do to try to increase your involvement with HIMSS, increase the information that we get from you all. So I would say that we are, as I emphasized before, I think that we are in a great place in terms of where IT fits into the larger healthcare system. I think we're on a path to a high-functioning learning healthcare system. IT is foundational to that effort. There are, a lot of signs in terms of things that are happening in the broader market that are I think are helpful to our drive to get IT better utilized, more appropriately utilized across the healthcare delivery system. So I'll stop there. That was a pretty quick rundown of